Hey guys, how you doing? Today we have an exciting case report to share with you. It explains step-by-step full mouth rehabilitation of an Edentulous patient with fixed full arch implant supported prostheses.
Let's review it together.
Well, we will be discussing the full mouth rehabilitation of an Edentulous patient with fixed full arch implant-supported prostheses. This is a remarkable treatment option for patients who have experienced chronic periodontitis and have lost their posterior teeth over a long period of time.
That's right. When patients suffer from chronic periodontitis, it can lead to supraeruption of the teeth and occlusal disharmony. Eventually, this may result in extraction of all remaining teeth. In such cases, fixed implant prostheses have become increasingly popular as a solution for completely edentulous patients.
Well, in the next part of our video, we will delve deeper into the specific details of the case report and discuss the patient's treatment journey. The patient in this case was a 64-year-old man with diabetes and hyperlipidemia who presented with a chief request for implant-supported restoration in the Edentulous area.
That's correct. Upon intraoral examination, it was observed that all remaining teeth showed sign of severe chronic periodontitis and had erupted beyond the occlusal plane. Unfortunately, extraction was unavoidable in this case.
Absolutely. After the extraction of all remaining teeth, the patient became fully edentulous. To address these, upper and lower provisional dentures were fabricated using the conventional centric jaw relation record method.
That's an important step. 3 months after extraction, the provisional dentures were duplicated as radiographic stents for dental CBCT to evaluate the alveolar bone status.
Right. Sinus lift and mandibular block bone grafting were performed at specific sites in both the maxilla and mandible under general anesthesia. After 6 months of bone grafting, CBCT was performed again to evaluate the alveolar bone, and a decision was made to place a total of 20 implant fixtures.
That's quite a significant number of implants. These implants were placed from the canine to the second molar on both maxilla and mandible. Surgical stents with parallel holes were fabricated based on duplicated dentures for precise implant placement.
And during osseointegration phase of the implants, the provisional dentures were adjusted and realigned with a tissue conditioner to optimal fit and function. After 6 months, the second stage surgery was performed.
Following the second stage surgery, impressions were taken using individual trays and pickup type impression copings. Silicone impression material was used for provisional restoration, ensuring accuracy.
That's right. The next step involved selecting the appropriate abutments. Master casts were fabricated, and it was determined that the implant angulation allowed for restoration in a one-piece superstructure. The patient's vertical dimensions were maintained based on their adaptation to the former dentures.
Absolutely. Provisional restorations were designed using CAD software and delivered in the mouth with temporary cylinders. To ensure proper fit and aesthetic, a TMJ series was taken and the vertical dimension was verified.
That's an important consideration. Once the provisional restorations were deemed successful, a final impression was taken to make the definitive prosthesis. Pickup type impression copings were used, and the splinted copings from the provisional restoration were incorporated.
Following the impression procedure, the jaw relation record was acquired, then transferred to an articulator for further analysis.
Correct. To fabricate the customized abutments for the screw cement retained prosthesis, cat software was utilized, and a full contour wax up was performed to create the metal framework.
That's right. The metal framework was then cast in palladium and gold alloy suitable for high fusing porcelain. The adaptation of the metal framework with the abutment was checked and one-piece metal superstructure was created.
Finally, porcelain buildup was performed, taking into account the occlusion in both the maxilla and mandible for aesthetics. The abutments and final prostheses were checked in the mouth and luted together with self-adhesive resin cement.
That's a crucial step. The provisional prostheses were reconnected and the patient was instructed to return for a follow-up visit. After 1 week, the definitive prostheses were delivered and occlusal adjustments were made to achieve proper canine guidance and mutually protected occlusion.
Exactly. From the panoramic view, it was evident that the prostheses were well connected to the fixtures. To protect the porcelain occlusion, the patient was instructed to use a night guard.
This case highlights the step-by-step process involved in such a complex rehabilitation and showcases the positive outcomes that can be achieved.
Absolutely. Also, the article highlights the choice between a fixed or removable implant prosthesis should be based on patient's preference, financial status, and the condition of residual ridge. In cases where the residual ridge is favorable and the patient can afford bone grafting, a fixed implant prosthesis like the one in this case can be selected.
That's an important point. The superstructure in this case was fabricated as a screw cement retained prosthesis for its passivity, retrievability, and the ease of access cement removal. The implants were placed parallel enough to allow for an ideal path of prosthesis insertion.
Right. The authors also discuss the concept of cross-arch stabilization and its advantages in reducing marginal bone resorption and mechanical complications. In this case, since there was insufficient anterior bone volume for implant placement, the implants were placed in the posterior area and restored as a one-piece splinted superstructure.
That's correct. However, the article acknowledges that obtaining a passive fit of the splinted prosthesis can be more challenging compared to a fixed segmented prosthesis. In this case, the authors employed a technique of rounding off the hexagonal connections of the abutment to achieve a passive fit and reduce preload stress in the abutment interface.
Long-term success and fewer prosthetic complications depend on regular observation and maintenance of the implant abutment interface. It's crucial to ensure the stability and integrity of the prosthetic components.
Absolutely. The discussion also addresses the issue of mandibular flexure and the need to split a one-unit fixed implant prosthesis to accommodate for mandibular distortion during mastication and mouth opening. This technique can help reduce screw loosening and marginal bone resorption around the implants.
That's an interesting point. To sum up the case, for this patient, a one-piece splinted metal substructure was used to achieve cross-arch stabilization. The article reports that there was no significant marginal bone resorption or patient discomfort observed during the 2-year follow-up period.
That's a positive outcome. The authors emphasize the importance of a regular checkups, patients' education on oral hygiene, and maintenance care for the long-term success of the implant-supported prosthesis.
And at the end, it's noteworthy that the patient in this case expressed satisfaction with the definitive prosthesis in terms of aesthetic and functional recovery. This suggests that the one-piece superstructure not only meets the patient's expectations but also has a promising prognosis.
Well, that's it, friends. Thanks for joining us today. We hope you learned something new.
Sure, don't forget to join the Purple Biopsy family and never miss a moment. Goodbye.